First of all, we would like to say we are so glad to be here in this important medical conference with doctors from many parts of the world. We would like to say thank you to Dr. Flavio. Unfortunately, he can't come to here, but he always helping us in our research. Before we start our presentation, it's worth mention that the patient stayed here knows and agree with everything, and no conflicts of interest is declared by the authors. Our research is talking about the neuroendocrine tumors, making a case report and a review. Neuroendocrine tumors, or NETs, are derived from neuroendocrine tissue found in various organs such as hypothalamus, thyroid gland, pituitary gland, adrenal medulla, and gastrointestinal tract, whose main prime site is the small intestine. Usually, this kind of tumor show no prediction to sex or age. In terms of history, in 1888, Lubitsch found multiple nodules in distal ileum. He found the first nets. In 1907, Oberdorf, when researched tumors in the ileum, classified all the serotonin produced are carcinoid tumors. And in 2000, the World Health Organization decided to classify the tumors, carcinoid tumors and pancreatic endocrine tumors such as NETs. About the characteristics, the main feature of these tumors is that they synthesize, store, and secrete a number of peptides, doing that in an ectopic way, which may mimic many other diseases, thereby delaying the diagnosis. They have a biological behavior ranging from slow to accelerated growth. However, most of these tumors have malignant potential, and 65 to 19% of the patients at the moment of diagnosis have metastasis, especially in the liver. Characteristics show a great chance of metastasis are prime site of the tumor, accelerated growth, presence of necrosis, and carcinoid syndrome. I will tell a little bit about the carcinoid syndrome because have a high incidence, 8-9%. This syndrome is correlated with amount of serotonin in the blood. The diagnosis can be done through the amount of serotonin metabolites in the urine exam, like 5-HIAA, and can be tracked by the stress, alcohol, and exercise. When you have this syndrome, the prognosis is worse. The main symptoms of that syndrome are not specific. Could be diarrhea, flushing. Flush begins suddenly and located in the upper part of the body, and abdominal pain. To illustrate the kind of tumor, I will tell a case report. In October 2014, a 69-year-old man came and complained about severe low back pain that started about 2 weeks ago. When I speak with the patient, he also mentioned that he had endured gastric pain for about 10 years. First, he was admitted abdominal CT, contrast tomography, which revealed a star-shaped lesion. Next, he did a contrast abdominal. He did a contrast CT, and the result that the patient had a hypodensis cyst in 4 apex segment, and the exam also showed a nodule on the root of the right mesentery associated with a fat striation, and no retroperitoneal or pelvic lymph node enlargement. Like you can see here, the star-shaped lesion. In face of this, a neuroendocrine tumor hypothesis was considered. Therefore, he was submitted to an open surgical procedure with a block resection of ileal segment, second, ascending colon, and a pectectomy. This a picture of the tumors, incision. The study pathology show a well-defined nodule of 3.5 per 2.5 per 2.3 centimeters in needle, two affects lymph nodes, liver node of 0.6 by 0.5 centimeters. The chromogranin A was positive, the cytography was negative, and Ki 6.7, more than 3%, were classified this tumor in intermediate grade 2. With that, the diagnosis of neuroendocrine finally was confirmed with metastasis in liver. After that, we recovered symptomatic and follow-ups were done with MRI. After 5 months, the MRI showed multiple hepatic nodules in 3, 6, and 7 segments. He was submitted to Crowne, but that exam has a low sensitivity in small size nodules. So that exam showed no viable carcinoid tumors. After the scan, he was submitted to another surgery just to remove the nodules. As a follow-up, MRI was performed each 6 months. This is a Crowne image. Regarding this case, our conduct was the primary tumor resection and liver metastasis with MRI follow-up each 6 months. In agreement with many retrospective studies, our patient conduct considered the best in terms of the overall survival. So, according to this, Marcela will discuss some studies about management and overall survival in order to illustrate what have been done with neuroendocrine patients in the world.
Thank you, Marcel. Now I will comment some important points of these studies. So let's proceed. This first study is from Dr. Philin and her group. It was published in Lancet Journal in 2014. It was a review from a conference that discussed the approach to neuroendocrine liver metastasis in order to serve as a basis for the development of clinical and research programs. And they conclude that MRI is better than CT for the diagnosis. Chromogranin A was considered as a follow-up marker since some retrospective studies demonstrate that 80% of decay is associated with the full resolution and stabilization of disease. They affirm that surgery is the only treatment capable of cure. However, the resection without microscopic margins is achieved in just 7 to 50% cases. Within this mind, the overall survival after hepatic resection in 5 years is about 46 to 86%. They don't indicate the biopsy of the primary tumor when the biopsy of the metastasis is conclusive. Aside from that, liver transplantation is a good idea due to the fact that the neuroendocrine tumors show slow biological aggressiveness and slow growth. But we should be aware, since it's not everyone that is eligible for this procedure. The contraindications are poorly differentiated tumors, non-portal system tumor drainage, extrahepatic metastasis, and severe carcinoid heart disease. At least, they recommend ablative techniques for unresectable lesions. In radiofrequency ablation series documenting a 5-year overall survival of 53%. Now, as you can see, this chart shows the superiority of the resection without microscopic margins in 5 years. Also exhibited lower overall survival in the other treatments. The resection without microscopic margins and the other treatments. The next study is by Dr. Lussertel and his group. It was published in 2013. It was a systematic review of 38 studies with the aim to determine the benefits and the risks of hepatic resection versus non-resection liver treatments in patients with potential or resectable neuroendocrine liver metastasis. They didn't identify strong evidence that a liver resection was superior to any other liver-directed therapies in improving overall survival or progression to disease-free survival. However, in 4 studies, the resection showed improved overall survival. Although in multivariate analysis, the resection was never associated with better survival. There was no evidence to support the use of cytoreductive resection to improve overall survival. Besides that, they didn't have sufficient data to affirm if the resection of the primary tumor would affect the outcomes. Another study performed by Dr. Valadares and his group was published in 2015 in Journal of Brazilian College of Surgeons. The objective of this study was to define prognostic factors in patients submitted to surgical resection of hepatic metastasis. It was a retrospective study with a total of 22 patients, and their conclusion was that the surgical approach is still the best predictor of cure, even if when a new approach is necessary. They found a 44% overall survival in 5 years when the surgical procedure is done. Now, in terms of negative prognostic factors, they found hepatic metastasis from pancreatic neuroendocrine tumors in cytometric patients with multiple metastatic nodules. Certainly, the conduct remains unclear, but what we have assurance is the surgery resection without microscopic margins is still the best option in terms of overall survival. Indeed, the neuroendocrine tumors are considered rare tumors, and as a result, few studies are found. It's clearly established that at diagnosis, 70% cases have liver metastasis. Despite the literature controversy, hepatic resection is only treatment that offers potential for cure, even if when a new approach is necessary. Definitely, the controversial management and the absence of a consensus was a big obstacle for us. Therefore, we consider this one of the limitations of our study, so future randomized trials are needed. Now, finish the presentation. I would like to thank all the organizers of this event and everyone present in this conference, in particular Professor Dr. Flower, unfortunately he can't came, and my brother Matthias. Finally, I would to thank all the components of this study and my parents that made this experience possible for me.
Thank you, Doctor. Thank you. Any questions from the audience? Before question arise, I ask every speaker to stick to the time. It's 20 minutes including the question time, so it's 15 minutes for the presentation and 5 minutes for questions. Please be mindful. Any questions? I've got one question personally. If you can go to the slide with the operative incision, and can you just go through the presentation? It was quite interesting topic and quite extensive localization of the tumors. So I'm wondering if it would be possible to do this from via midline laparotomy rather than going through Y-shaped incision, which is healing, according to our experience, quite longer. So is it preferable technique for incision in your clinic?
This incision was made for our profession. We don't know if we prefer to do that. We're not able to ask.
Okay, so sorry. That's fine. Any other questions? you.